Alright, so this is how we going over some EKG changes, and this is a uh, normal EKG. Roughly around PR interval we have is around 0.12. Excuse me. Alright, so we've got here a regular PQRST EKG wave. We got the PR interval and the PR segment, which is between the PR and the Q. So yeah, the PR segment is here. And let's see. And I'm going to ignore the PR segment because that's kind of, we don't really use it. At least I don't anyway. But I am going to focus on the PR interval. And the PR interval starts at the up wave of the P wave and the down slope of the Q wave. So this is around 0.12 to 0.20 seconds. And that's about 3 to 5 square big boxes. But just remember 0.12 to 0.20 seconds. Oh, did I say big boxes? I'm sorry. What I meant was it's 3 to 5 small square boxes. But again, just notice that it's 0.12 to 0.20 seconds. And the PR interval again starts at the upslope of the P wave and the downslope of the Q wave. All right, and next we have the QRS complex, which is right, which are right here. So QRS. And let's see. So this starts as a downslope of the Q wave and the plateau of the S wave. And the pointy part is the R wave. And this is from 0.08 to 0.12 seconds. And that's about 1/3 of the PR interval. So this is pretty important because the QRS usually measures the ventricles. And we're going to talk about the different changes of the ventricles, whether it gets bigger or smaller or whatever. And it'll definitely let you know whether or not the rhythm is shockable, because usually the only shockable rhythms are ventricular fibrillation and ventricular tachycardia. So VTach and VFib. There was one more that was shockable as well, but I kind of forgot that. But anyway, those are the two main ones. And those relate to the ventricles. All right, well, let me erase that. Next, we have the QT interval. ST segment, whatever. But the QT interval is important because a lot of the time when we give medications that affect, like antipsychotic medications, we usually check to make sure to see that it doesn't prolong the QT interval. Why? Because that leads to something called torsades de pointes. And we're not going to talk about it in this video, but it's just something that you want to look for, because this QT interval, which is supposed to be 0.35 to 0.43 seconds, if it elongates, it starts to try to kind of widen and broaden the EKG wave, and that it's going to lead to something pretty important. And a lot of the time, I say that a lot of the time, well, many times the electrolytes that you're giving or not giving the patient is going to cause a lot of these EKG changes. So you really need to watch over that really closely. Talk with your doctor. You are the nurse. You are at the bedside. You need to be able to look at the patient. And yes, the alarms are pretty important, but the patient first. Look at your patient. Is he or she not acting right? Discuss and talk with them. Then talk with the doctor and say, hey, I think the EKG numbers are off, and then my blood results confirm that. So let's want to talk about it before something bad happens. Okay, so let's go on to the EKG changes caused by electrolyte abnormalities. Hypomagnesemia. A lot of magnesium that we give. Oh, where's all that music coming from? Oh, it's from my Spotify still turning on. All right, anyway, so this wave right here is not to scale, but I just wanted you to see that the PR interval is prolonged and that the QRS complex start to get big. And again, the QRS complex talks about the ventricles and the PR interval. It's mostly related to the atrium, so which are the two chambers above the heart, or two chambers of the heart above the ventricles. Anyway, so we have a prolonged QR interval. Prolonged PR interval. So it's greater than. Oops, let me use. Greater than 0.12 to 0.2 seconds. So it's more than that. And you'll start to see this kind of like around here, and it's a longer interval. Then you have the QRS complex, which is normally 0.08 to 0.12 seconds. And this gets big. Something is going on with the ventricles. It's taking a longer time for it to depolarize, which is basically just a fancy word of squeezing. And then, so you kind of want to focus on this part of the EKG. Wow, that's a lot of, that is a lot of notes. But anyway, so hypermagnesemia, it elongates the PR interval as well as widen the QRS interval. Oops, forgot to mention that hypermagnesemia is anything above 2.1 milliequivalents per liter. And a lot of the common food sources include avocado, which I love, canned white tuna, meh, cauliflower, green leafy vegetables, milk, oatmeal, peanut butter. I love peanut butter. A lot of stuff has a lot of magnesium, I find. So, so hypermagnesemia 1.3 to 2.1. Sometimes I remember it as around 1.5 to 2.0, which is a very small number, narrow range. And a way to remember that is like magnesium sounds like magazine. So you got around 1.5 to 2 magazines. It's supposed to look like a magazine. I don't know. I know I can draw better than that, but that's what you're getting. It's free video, so if you're listening, you're getting what you get. Again, so hypermagnesemia has prolonged PR intervals, wide QRS complex. It's defined as greater than 2.1 milliequivalents per liter for your patients, and the common food sources are described below. Next. Oh, so I almost forgot. So the cure for hypermagnesemia, as a nurse, you're probably going to give diuretics so the patient can pee it out. And diuretics include, of course, hydrochlorothiazide, Lasix, which is furosemide, and there's a third one that's an alternative to Lasix and hydrochlorothiazide is Oh, I should know this. Hold on. Yes, chlorthalidone. Let me spell that. Chlorthalidone. Don't see that very often. Anyway, diuretics. So you want to pee it out. Pee out all that extra magnesium. Now, what happens if you give a lot of diuretics? Well, as a nurse, you also have to be concerned about losing a lot of potassium. So you accidentally pee out the magnesium and the potassium, and that could be no bueno. And we'll talk about the EKG changes that potassium will do. And so in addition to diuretics that you're giving the patient, you are also going to give them a antidote. Oh, can we say antidote? Maybe something that'll help take out the extra magnesium. Without going on through the regular general chemistry of it all, but calcium, chloride, is going to be a treatment for increased magnesium, and calcium gluconate as well. I'm pretty sure the oxidation is 2+ on calcium. I don't know. It's been a while since my basic chemistry, but the fact is that these two are going to be the cure for hypermagnesemia, as well as whether or not you're going to give diuretics with it as well, or you give one or the other, depends on your doctor. But whatever you do, your doctor does decide to give, make sure that you are watching your patient, watching your patient, watching your patient. So since that was hypermagnesemia, let's go with hypomagnesemia. It says exaggerated, so just so you know. Hypomagnesemia is defined as, let's use yellow. Well, you know what? Let's use green. Oops, we're blocking that. Defined as less than 1.3 milliequivalents per liter. Now, it depends on your hospital policy when you might want to do something about that, but yeah, definitely as a nurse, you want to take a look at any values below that. And again, of course, refer to your hospital policies about what numbers you really look at as far as laboratory values. But Saunders is a pretty dependable resource, and I use Saunders a lot. Anyway, common food sources again. Hypomagnesemia. What does it do to the EKG wave? Well, it has tall T waves, so it usually goes, and well, it's not that tall, but it's a little bit of an exaggeration. But maybe let's go like this tall. And depressed ST segment. So where's the ST? Oh, you know what? I guess this thing had a use after all. So the ST segment is here, where it plateaus, the S wave plateaus, and the before the T wave slope comes up. So this is a ST segment, and depressed meaning it's kind of the opposite of ST elevation when people have heart attacks, and angina, and wait, not angina, but let's see, like an atrophied muscle due to a heart attack. So like God, there's another word for it. Not cerebral vascular accident. God, like why I can't think right now. I'm kind of pretty tired. Anyway, so it's the opposite of ST elevation, so it's actually ST depression. So it's when it stays down like that. So it's kind of you expect it to be up here, but instead the plateau is down here. So that's hypomagnesemia, and then you've got tall T waves, and so it's mostly affects this part of this part of the EKG wave. So that's a small hypomagnesemia, and again, we're also worried about EKG changes. And I forgot. I need to talk about the antidote for hypermagnesemia. But anyway, causes include inability for the body to absorb enough magnesium. So a lot of GI diseases like Crohn's disease, ulcers, stuff like that. And what you're going to do as a nurse is you're probably going to give magnesium sulfate, so mag sulfate, IV through an IV line in the patient's arm. Ouch. And it hurts pretty badly, so check to make sure that it's not causing too much pain and that your lines are working well. Now, one thing about magnesium, not having enough magnesium, and then you're giving mag sulfate, is that hypocalcemia also follows that. So also watch that, and we'll talk about hypocalcemia later. And then also, if one thing wasn't enough, you might also want to watch out for hypermagnesemia if you're giving the patient a lot of magnesium IV. And that looks like your patient is not having a lot of deep tendon reflexes, so the DTR, so it's slower for them to react when you, let's say, press on their tendons with a reflex hammer. And also better for you as a nurse to know your patient, because if they start kind of looking a little sluggish and feeling really lackadaisical and tired and lethargic, then you may want to start thinking about that and ask for another blood draw, something more current. Okay? And next we have hyperkalemia. Kalemia is for K, which stands for potassium. And the reason why it's called K is because uh, hundreds and thousands and how many years medieval times were, is the English would take potash out of plants and evaporate it somehow, and that's when they would get a piece of calcium salt, and they would use that as plant fertilizer. Nowadays, we don't really need to do that, and plus it takes too long and too many resources. So anyway, the English symbol for potash is K, which stands for kalium. And kalium is somehow related to the word alkali, which is basic, basic part of the pH balance that the body depends on. So you can see that potassium is really pretty important. And the interesting thing about potassium is that it's inside your body's cell, so it's intracellular. So this is your cell, and the potassium is in there. Bloop. And it likes to stay in there. It's like a frat boy. It's like kappa, 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 like kappa, whatever. Well, that's a terrible analogy. But anyway, the potassium is usually inside the cell a lot. And sometimes something happens and it starts busting out of the cell, and that's not good. So it also causes a lot of EKG changes, and we'll take a look at that now. So let's take a look at this, and we have tall peak T waves, just like we saw in the potassium. In the previous one. What did we talk about in the previous one? Like in hypermagnesemia. Yeah, so tall peak T waves. We've also got a widened QRS. Again, QRS usually lasts around 0.08 to 0.12 seconds. So anything longer than that is a widened area. And again, the QRS complexes affect the ventricles. Next, we have a prolonged PR interval. So the PR interval is usually 0.12 to 0.20, pretty longish compared to the QRS complex. So we've got a long PR interval, a widened QRS complex, and a high T wave. And it affects, let's see, like I said here, basically just everywhere. So that's how you can tell it's really pretty important for hyperkalemia not to occur, and you need to make sure your patient never, ever gets there. So potassium is defined as like 3.5 to 5.0 is the normal value, 3.5 to 5.0 milliequivalents per liter. And again, some hospitals, look around anything less than 3.0 as to be pretty bad, or anything higher than 5.5. It all depends on your hospital, but the main numbers that are usually seen is a good normal numbers between 3.5 to 5.0. And so since we're talking about hyperkalemia, we don't want the patient to be have more than 5 milliequivalents per liter. And otherwise, that is defined as potassium, hyperkalemia. And it comes a lot from avocados. Again, those avocados, they've got everything, but a lot of fruit there too. Bananas, cantaloupe, oranges, strawberry. Of course, we know a lot of potassium comes from bananas. That's pretty famous. But we also didn't know that I didn't know that it didn't come from tomatoes, carrots, and all that. And got pork, beef, they have everything. So this is pretty bad. Your heart depends on, if I remember my biochemistry classes correctly, is your heart depends on an anion pump where a lot of energy occurs, energy transfers. So you got your potassium here, and your calcium, and something goes in, something goes out, and the world keeps turning. If that's wrong, please correct me. But I just wanted to emphasize that you need potassium to make your heart move. And since the potassium is inside the cell, you can also lose potassium if the potassium escapes. Okay? So, again, just like with all these electrolyte imbalances, you can either have a excretion problem with your kidneys where you can't pee out the actual electrolyte. So with a lot of these increased electrolyte imbalances, it can occur from trouble with your kidneys, and trouble with just getting it out of your system, or putting it in too much somehow. Either the patient doesn't know what he or she is doing and is taking in way too much of one particular electrolyte and is causing problems, or he or she cannot excrete it or pee it out. So this is a problem. You can see how it's affecting so much of the EKG wave. And so your patient is not in good health if he or she is hyperkalemic. So what are you going to do? Well, nursing school, they really hammer in that as a nurse, you're going to give sodium polystyrene. It sounds like I always think about what do you call those cups? I can't think today. That's right. Styrofoam cups. So, kind of those old styrofoam cups that you got from 7-Eleven, or it's like an old timey burger joint. Anyway, so this is also known as, say it with me now, K-exalate. Yay. So that is one of the main treatments for people with hyperkalemia. Okay, another treatment is IV calcium. Calcium and potassium, they go together, so you can use a lot of IV to prevent any heart trouble, because you're gonna... Oh yeah, remember my little heart um, ion pump. Did I say anion? Just ion pump. Where potassium is inside and calcium is outside, and I don't know if that's oxidation. I really should check my oxidation levels. Anyway, so calcium trying to come in, potassium trying to come out. So if you balance out the excess potassium with excess calcium, it might balance out your patient's heart. So pretty important. That's another thing. So calcium deals with cardio, and caxylate binds potassium in the intestines. That's supposed to be your large and small intestines. And then you poop it out. You poop it out. So it works in the intestines, and then you poop it all out. Next, what do we have? How do we address the issue of potassium being outside the body? It's not supposed to be there all the time. It's supposed to be back where it belongs, at home inside the cell. We can't have frat boys ruining the neighbor's yard, okay? What do? We give hypertonic glucose. So if normal saline is around 0.9% sodium chloride, well then anything higher than that, let's say, I don't know if it ever really goes past 3% or 2%, but hypertonic solution with insulin will shift the fluid balance and bring back the potassium inside the cell, because there's less osmolality inside. So the IV calcium fluids will shove all the more fluids inside the cell, and the potassium will go along with that, okay? So just make sure, though, that your patient doesn't, of course, become hypoglycemic because of too much insulin. A lot of stuff you need to watch out for. Very tricky balancing act, and the doctors depend on you to be able to make sure that it's not causing too much trouble for the patient, because we can't always see exactly what's going on unless we take a lot of blood, laboratory lab results. It's a little redundant. Anyway, caxylate for the GI tract, poop out that extra potassium. IV calcium to balance out the potassium within the heart for cardio, and possibly hypertonic insulin to push all that potassium back into the cell. Very important stuff, very tricky things. But before you even get there, let's, of course, take a look at some common sense nursing stuff. Stop taking in so much potassium, Stop infusions for the patient that has potassium on it. Don't let them have too many foods with potassium, which are noted here. And if you're transfusing blood for a patient, make sure that they have fresh blood and not stored blood, because stored blood has a lot of potassium in it. A lot of the K has come out of the cell, and it's not good for the patient. Okay? Wow, that was a long, messy, disgusting slide, but I hope that you get the realization that hyperkalemia is not a good thing. Next. Whew. So we're not quite out of the woods yet. We have another potassium problem, and that is hypokalemia. So we talked about how K stands for kalium, is a definition of potash, which is an English, old medieval English description of potassium when they would try to get out of tree bark or whatever for plant fertilizer, which we no longer do, but the name K for potassium stuck. Anyway, so the difference between hyperkalemia and hypokalemia is not enough potassium. So that's usually less than 3.5 milliequivalents per liter. Again, check with your hospital policy to determine whether or not 3.0 is exactly when you start raising some red flags, or anything less than 3.5. And then also check to make sure that our lab standards here are the same as your lab standards in your hospital facility or what have you. So what does it do for the EKG changes is it does an ST depression. Well, this ST segment is much more important than the PR segment, I just have to say. So again, ST depression, bloop, where it just kind of doesn't plateau back to where the rest of the lines follow. And then you also have a shallow, flat, inverted T wave. So this T wave can be like shallow, and also like an extra little bloop, an extra little wave, U wave. Let me double check that. Oops, I was kind of on the right track, but not really. Anyway, the U wave follows the T wave. However, it's not an inverted T wave. It's also just another small T right before the next P and the next wave comes along. So we've got the depressed or inverted T wave. Oh, depressed. And we also have a little U wave following right behind. So it's kind of like a groupie, like a little fan wave, a little like a little secret admirer. Boop. It just kind of follows the T wave right along with it. So it's not really. So this would be like an inverted T wave, and this would be like a little T wave right next to it. So again, it's like that, and there's a T wave, and there's a P wave again, and then blah. Okay? So this would be the U wave. This would be the T wave. Okay? Makes sense? And let's see. Now, the thing about hypokalemia is it's also a problem, of course, with the heart. But the tricky part for nurses, I think, is giving the treatment. Because for hypokalemia, the nursing interventions include giving potassium, because the patient needs potassium, right? So you can either give potassium by a tablet that the patient can eat, and if it stops at that, great, fantastic. Patient gets his tablets, his potassium. He or she is fantastico. However, it's never that easy. Wonk wonk. Usually, sometimes patients feel sick and they vomit. Blah. So nausea and vomiting occurs. If that happens, then we have to move on to potassium IV. And that comes with its own problems, because this potassium, that's supposed to be a potassium bag. Where is it? Oop. The potassium into the patient's. That's supposed to be a hand. What a terrible looking hand. No wonder the patient's sick. Anyway, the potassium goes into the IV, into the patient. However, it is irritating. It's like little thunders. So we try to keep the rate of the potassium level to be around or less than 10 milliequivalents. Where was I? Oh yeah, so a nice infusion rate is usually 5 to 10 milliequivalents per hour, as far as I know. And yeah, if for some odd reason you really have to give the patient a lot of potassium really quickly, then if it goes up to more, like we're talking about 20 milliequivalents per hour, I've read, now don't quote me on this because it all depends on your hospital again, I don't want to be liable, but you stop doing it through peripheral, you really monitor their heart because it is very important. So you're looking at EKG in the monitor, and some people may give it through a central line, which is closer to the heart. So let's say your heart is here, and then your, let's see, vena cava, and yeah. So the central line is, let's put more room, and so the patient heart is there, and patient central line can either be here or straight up here. Oh, there's a head. There's a head. And either way, it goes straight into the heart, okay? So we end up giving the potassium that way instead of having it go to just the vein and then just doing it, the long way around. We do it straight central line, okay? Very, very important, very, very risky stuff. You need to be able to make sure that, hold on. Oops. What's going on? Zoom in. Oh, well, there you go. Where we're at. So you need to make sure that your bag is actually potassium and that you're giving it the right way, right time, right dose, right patient, right documentation, right patient, right drug dose documentation, patient route time, make sure there's no allergies, contraindications, stuff like that. So what are the ways for you to mitigate these risks is when you're giving the rate of, again, usually 5 to 10 milliequivalents per hour, or if you have to go all the way and ramp it up to 20 milliequivalents per hour, that you make sure your banana bag, your potassium bag, is correct, okay? So a lot of the time, the hospitals that I've seen already have this bag pre-made and diluted to a specific solution. So make sure that that bag is pre-made, but you're still liable for checking. That's the nurse. Bloop. Just making a. For checking, making eyes on the patient bag, that is the right bag that you're giving, okay? Because you don't want this patient to get hurt. Whew. Next. Next we come to hypercalcemia. Again, a lot of the time when people have an increase in electrolyte imbalance, then they have a problem with either increased absorption of hypercalcemia or trouble excreting it from the body. So if there's an increased bone resorption, let me draw a little bone, bloop, and you know, you take a lot of calcium or you take it from the bone too much and it goes out into the body, well then, that's supposed to be 2 plus, but whatever. Anyway, so then it gets recycled into the bloodstream, and that's not good. Too much or not enough is never a good thing. Everything is always in balance with the body. And this involves an ST segment that is smaller. So you'll see an ST segment here, and then the T wave comes up really quick. And actually, I should draw the T wave a little bit wider. So you'll see a wider T wave, and this is where the calcemia happens. Calcemia just mostly deals with this stuff right here. So hypercalcemia will deal with the QT interval, decreasing the SE segment, and really emphasizing this T wave. Loves this T wave. Hypercalcemia, you'll love your tea. That was a lot of work for not a big payoff for the joke. Anyway, so yeah, hypercalcemia, again, increased T level. So your doctor will probably given some acetylsalicylic acid. To me, that's aspirin. Also will give NSAIDs. Also will give some calcium blockers like bisphosphonates. What else? Yeah, bisphosphonates, calcium, calcitonin, and phosphorus inhibitors. So it's going to inhibit calcium's friends to make sure that it stays in line. And you really see your patient have a profound muscle weakness. So it won't be able to get big anymore. So this is supposed to be in the muscle. So the patient becomes wonk, wonk, really tired. And this is my cartoon style muscles. So muscle impairment. Because, you need a lot of calcium to help out with muscle contraction. But too much calcium, not a good thing. Actually does the opposite. All right, moving on. Hypocalcemia, not enough calcium, that affects, let's see here, we got a lot of blue. So again, mostly this part of the EKG wave deals with, yes, the ST segment again, but doesn't really like the T, or doesn't work with the T because that's mostly for hypercalcemia, but without enough calcium, the T is left alone. However, the QT interval is prolonged, and the ST segment is prolonged too, so it's really long. Wait, maybe the T is fine, but the interval is long. There, see? T is okay, but it's just far away from home. So the fun part to me with hypocalcemia is, besides the EKG changes, is the signs that you can see when a patient has a chopstick sign or Trousseau sign, which indicates hypocalcemia. Hold on, let me see if I can get this thing to work. Oh, hey, there you are. I couldn't find a way to use a video, so I'm just going to demonstrate the chopstick sign. It's usually a facial tic that occurs when you just lightly tap on the patient's cheek, so it's going to look like this. I don't know how my acting was, but that is it. Yay! Did that work? Let me see. Whoops. Oh, hey, there you are. I couldn't find a way to use a video, so I'm just going to demonstrate the chopstick sign. It's usually a facial tic that occurs when you just lightly tap on the patient's cheek, so it's going to look like this. I don't know how my acting was, but yeah, there you go. And then there's a trousseau sign, is when you put a blood pressure cuff on a patient's arm, which you'll probably do a lot. But you tend to notice that the patient's arm makes a little, like the fingers point. This makes like a little duck neck, like a little bill, and it starts to move as if it was being squeezed. Well, let me demonstrate it to you by video too. All right, so the chopstick sign. Where's the camera here? So imagine that the blood pressure cuff is here. That's my tattoo. It looks weird right now, so it's not done. Anyway, so you put the blood pressure cuff here, and then all right, so I didn't record it. Anyway, so this is my arm, or the patient's arm, and I put the blood pressure cuff here. Ignore the tattoo. And then as you squeeze the blood pressure, you'll see the patient's arm start to kind of like, and that's a trousseau sign. Did that work? Let's see that. All right, so I didn't record it. Anyway, so this is my arm, or the patient's arm, and put the blood pressure cuff here. Ignore the tattoo. And then as you squeeze the blood pressure, you'll see the patient's arm start to kind of like, and that's the trousseau sign. All right, so there you go. You've got power. You got the chopstick sign, which same two words for cheeks. And then you got the trousseau sign, because, I don't know, because your hands start to look like a T. I just made that up. All right, so there you have it. You have the different EKG changes for three main electrolytes that affect the heart and the EKG, and that's the EKG that you see and you monitor when you're in the tele cardiac unit or the ICU. There's also, of course, more electrolytes than that, but I just chose to focus on these three, whether it's hypo and hyper, because they're the ones that come to my mind the most. So just a little bit of a recap. If you have hyper anything, it's usually because the patient took in too much. Okay. So the patient took too much electrolytes and it's no bueno. Or the patient, this is supposed to be the intestines. It's accumulating too much in the intestines and the GI tract, and then also in the bloodstream, and then now your kidney, the patient's kidneys, can't do their job, and so it builds up even more. Okay, that's where you have hyper anything. Next, if you have hypo, and you know what, I shouldn't say anything, because when I meant hyper anything, I meant these three abnormalities in electrolyte abnormalities only. I mean, of course, there's always lots of different stuff about science and medicine and all that. So, which is why I like it, and probably why you like it too. But when I say anything, I just mean these slides. So if they have hypo anything, then you have to start figuring out a way to infuse your patient, or not even just infuse, but us either orally intake or parenteral, which just means like needles and stuff, to go into your patient, okay? So they can get the electrolytes that they need back. And knowing that, you can be able to, you know, get their heart back to normal and have a nice little EKG reading. Well, you know what a normal EKG reading looks like. So I hope this was very helpful. It's kind of long. It helps me a lot, and I hope it helps you too. So if you have any suggestions, comments, say, hey, Howie, this was dumb. Don't just tell me it's dumb. Tell me why it's dumb. You know, like, what should I do differently, or what did I say wrong? And then comment below and let me know so I can make sure that I don't do it again. And if you like this and you want to suggest another video, let me know, okay? All right, fellow nurses, keep at it. Keep taking care of your patients, and enjoy your job. Don't forget to subscribe to moi, Nurse Howie, and we're going to get along just fine. Okay? Good night.